So, welcome everyone to BiteMedicine's 63rd webinar. Today we're going to be covering ulcerative colitis, so finishing off our series on inflammatory bowel disease. My name is Azim. I'm one of the co-founders of BiteMedicine, for those of you who do not know me. Obviously, I'm sure most of you have seen Schwabe around as well. He will be lurking around in the chat and the Q&A, so if you have any questions which I can't get round to, then feel free to pop a message in the Q&A and he should be able to get to you. So let's dive in with some objectives and some other kind of housekeeping announcements as well. So as I said, we're covering ulcerative colitis today. Our target audience is going to be medical students in your clinical years and physician associates as well, aiming for this to be around 60 minutes, 65 minutes, something like that. We covered Crohn's disease, probably a couple of weeks ago now. So we had our medical competition thingy last week, which you guys seem to really enjoy. So we'll definitely do that again. So if you haven't seen the Crohn's disease webinar, check that out as well. And then, yes, this is really building on that essentially. As usual, we're going to be building on like our normal pathophysiology, clinical features, etc., multi-step SBAs, and then we'll do a Q&A at the end as well, a brief Q&A, and our top decile question as well. In terms of housekeeping, as I said, as you probably know, we've paused our certificate scheme for the moment, but please do leave feedback right at the end, because that is the only way we can improve. So we'll be super, super grateful if you could do that. So without further ado, let's dive into our case for today. So we have a 25-year-old male who's presented to his GP with a 3-month history of small amounts of fresh blood in his stool and loose stool as well. So there he is, poor chap, on the toilet with his loose stool and his fresh blood as well. I made that myself, so I'm quite proud of that, but there he is. I feel very sorry for him. He's currently opening his bowels 3 times each day, usually fit and well, works as an accountant, and smokes cigarettes occasionally. So just looking at those observations, obviously we're thinking this is ulcerative colitis, and we're going to build on the logic and reasoning behind why we think that is. But just looking at the observations, are we concerned, not concerned, a little bit concerned? What do you guys think? See the chat. Any thoughts? No? Anything at all? Worrying? Looking at those? No? Yeah, I agree. Obviously the history is concerning for inflammatory bowel disease, but I totally agree. You know, looking at those obs objectively, I wouldn't be concerned really. So diving into our first question. So based on that history we just said, we obviously think this is ulcerative colitis. Which of the following is true of the likely underlying diagnosis? So for those of you who haven't been to one of our webinars, we use menti.com. So please do not answer in the chat if at all possible, and just head over to menti.com and pop in the code that you see there at the top of your screen, 5980115, and we will work through this together. Let's see the chat. Okay, interesting questions in the chat. Something about wedding bells. I don't know what to say about that. Missed you too. Cool. Okay, I'll let a few more of you answer. Okay. Nice. All right, so a nice easy one to start off with. Absolutely right. So, we obviously, as I said numerous times, this is a webinar on ulcerative colitis, so we think this is ulcerative colitis, and this is absolutely correct. Ulcerative colitis, out of these options, you know, it's the only one that involves the large intestine. Obviously, there are extra-intestinal manifestations as well, but the most correct of these options is going to be that one. And as you can see from the other options, they're explaining why those other options are incorrect as well. So that's really just to ease you into things. So why do we think that this patient has ulcerative colitis? I have a whole couple of tables comparing lots of different bits between ulcerative colitis and Crohn's disease, but just, on a basic level, we think that this chap has ulcerative colitis because, 3 months is a reasonable history. So nice to actually say, above 6 weeks of fresh blood in your stool, or diet loose stool with fresh blood, for example, is suggestive of ulcerative colitis. So this is 3 months fresh blood. So ulcerative colitis almost universally affects the rectum, and that's why the vast majority of patients experience fresh blood in their stool. He's got loose stool as well, and he's opening his bowels 3 times a day. So yeah, all very, very suggestive of UC. But as I said, we'll have a comparison of UC and Crohn's disease later on. Lovely. So introduction to ulcerative colitis, a relatively straightforward topic in the grand scheme of things, I feel. So it's a form of inflammatory bowel disease. Go check out Crohn's disease if you haven't seen that already. As I just mentioned now, it almost universally affects the rectum, and then it extends proximally. So as you can see on this diagram here, you've got the rectum, and in this case, it's affecting kind of the sigmoid, the rectum, the descending colon, splenic flexure, and part of the transverse colon as well. So yeah, the key point here is that almost all patients are going to have rectal involvement, which then extends proximally. As opposed to Crohn's disease, where you can have the presence of these skip lesions. In ulcerative colitis, you have involvement of continuous portions of bowel. So as you can see here, this is a continuous portion of bowel that's being affected, rather than skip lesions, which are seen in Crohn's disease. As the first question highlighted, ulcerative colitis only affects the large bowel, so it never spreads proximal to the ileocecal bowel. So if you start moving proximally over here, it's never going to move into the small intestine. So if you have inflammatory bowel disease, which is affecting the small intestine, you can be pretty confident it's going to be Crohn's disease, because ulcerative colitis does not affect the small bowel. And in terms of why patients get UC, well, it's one of those things in medicine where I'm going to say something pretty wishy-washy, which is, it's a combination of genetic factors, environmental factors, and potentially some immune dysfunction as well. In other words, we're not entirely sure why people get it, but it's a combination of different things. So yeah, sorry I can't give you more information about that, but I'm sure there's some interesting papers on why we think UC occurs. So looking a little bit closer with our microscope now. So if we look on a microscopic level, we have to understand what is going on in the gut of these patients. So a few key points. So in ulcerative colitis, we have mucosal and submucosal ulceration only. This is in comparison to Crohn's disease, where you have transmural inflammation. So inflammation of all layers of the bowel wall, where in UC, it's just going to be mucosal and submucosal involvement. If we look at these two images here, these are both obviously biopsy samples. I'm not a histopathologist, but the one on the left shows apparently marked lymphocytic infiltration within the intestinal mucosa. So obviously you would expect inflammatory cells to be moving into the mucosa. So that's what this one shows. And on the right over here, if you look at this one right in the middle, this is an H&E stain of a colonic biopsy, which shows a crypt abscess. And crypt abscesses are classic findings in ulcerative colitis, which is what the second bullet point is saying. So yeah, these are just some pretty images that I found, just to help you guys visualize things a little bit more. Delightful. Now, this is a really important slide in order for you guys to understand the management, because the management of ulcerative colitis, it's not very sexy. I'll be honest with you. When you get to the slide on management, there's a lot of tables, which are not massively exciting, but the only way that you guys are going to understand the management of UC is if you understand this slide. So let's work through this. Obviously, there are lots of pretty colors. I like pretty colors. So this is essentially, this diagram is classifying colitis for you, and it's defining the extent of involvement of ulcerative colitis. So it's obviously labeled. I'm sure you guys know this basic anatomy anyway, but let's work through these colors. So blue is representing proctitis. So if you have inflammation in the blue area, this is called proctitis. If you then have inflammation of the yellowish area over here, this is now proctosigmoiditis, which makes sense. You've got sigmoid colon here and you've got rectum over there. You then have involvement of the orange area over here. You then have, this is known as left-sided colitis. Once again, makes total sense. And then when you have red involvement as well, so essentially all of this is then known as pancolitis. So in summary, proctitis, proctosigmoiditis, left-sided colitis, and then pancolitis. So all of these classes then extend, usually going to be from the rectum extending proximally, but never past the ileocecal valve. Does that make sense to everyone? Let's take a look at the chat. I'm hoping that makes sense. Yeah. Where's the chat? Oops. Yes, I'm hearing lots of yes. Cool, good. So yeah, remember that slide. Obviously the slides are all online, so you can download them and just learn that diagram essentially, because that's going to be really important for management, as I said. So moving into some epidemiological bits and some risk factors as well. So similarly to Crohn's, ulcerative colitis has these two peaks or bimodal distribution of age in terms of its incidence. So you have a first peak in early life, like in this chap in our first case, 15 to 25 years old, and then a second smaller peak in elderly population, so 55 to 70 years old. Nice and easy. Risk factors, HLA-B27, so your human leukocyte antigen B27, Caucasian. Then obviously the third bullet point, which is still a little bit controversial, but has been shown to demonstrate some relationship over here. So smoking appears to decrease the severity of ulcerative colitis, which, you know, in terms of how this is, what advice we're going to give patients in a clinical environment, obviously you're not going to say, you know, make sure you take up smoking because that's going to help your UC, because that's not what you're going to say. It's about, you know, balancing out your risks and benefits of smoking. Really, there are very, very few benefits of smoking. But in this case, smoking has been shown to reduce the severity of UC. So in reality, if a patient is smoking a lot of cigarettes to, you know, prevent relapses in their UC, then what you really need to do is optimize their medical therapy whilst also encouraging smoking cessation at the same time. So that's a really important relationship to be aware of. And finally, NSAID, there's some recent evidence to suggest that they may precipitate a flare, but once again, the jury's still out on that one. So nice and easy, that's really in terms of the basic epidemiology and risk factors. Those are the main things that you guys need to understand. Cool, so I've talked enough. Let's move on to another question. So which of the following features is least associated with ulcerative colitis? This was the question. I had some issues loading. Let's see if it loads. Yes, lovely. Okay, let's go through the Q&A. I always regret opening the Q&A. Don't think I can answer any of these. You should have a session where you just read your first messages and react. That would be hilarious. Yeah, I think that would be hilarious too. The rest of these, I don't think I can answer, but thank you. Let's see what you guys think. Okay, a little bit of a split. Boom. Anal fissures. Those pesky little things. Remember what we said right at the beginning? So you've got rectal involvement almost universally, which usually extends proximally. And this question is just highlighting that key point, that there is no anal involvement in ulcerative colitis, whereas Crohn's disease does affect the anus. So you would not expect anal fissures in a patient with ulcerative colitis, because ulcerative colitis affects the rectum and extends proximally. Obviously, the anus is distal to the rectum, so there is no anal involvement in ulcerative colitis. Nice and straightforward. All of these other 4 features can, of course, occur in UC. And if you haven't heard of some of these before, we will be covering them very shortly. Okay, moving swiftly onward, some clinical features. Some of these we have touched on already, but they are nice and simple. So before we touch on really every single one of these, just one thing to point out at the top over here is that UC, like Crohn's disease and like a lot of inflammatory conditions, goes through this relapsing and remitting course, which basically means that there are going to be periods where patients are essentially symptom-free or relatively symptom-free, which is known as remission, and they then have flares of their symptoms, which are known as relapses. So the key is to try and get patients to be as asymptomatic as possible and remain in remission for as long as possible. And then this, once again, will come back into our management and how this affects our management. So some clinical features of ulcerative colitis. So symptoms: loose stool, diarrhea, fresh blood, mucus in your stool. Because you have rectal involvement, you can often expect some elements of rectal symptoms, such as fecal urgency, incontinence, tenesmus. These are all rectal symptoms. So these would be very, very expected in a patient with ulcerative colitis. Abdominal pain, as we know, ulcerative colitis most commonly is going to affect the left side of your colon. So particularly, they're going to have left lower quadrant pain. Weight loss, malnutrition. Now, this is going to be more common in patients with Crohn's disease. Crohn's disease, because it affects your small bowel, can have really profound weight loss, really profound malnutrition, but it can occur to a smaller degree in ulcerative colitis as well. Signs: abdominal tenderness, fever, fresh blood when you do rectal exam, and then various extra-intestinal manifestations as well, which we will cover very shortly. So nice and easy. Nice specifically say that you should really suspect ulcerative colitis in any patient with bloody diarrhea that is persisting for more than 6 weeks, or a patient with rectal bleeding, if you are confident that this isn't malignancy, essentially. If you're confident it isn't colorectal cancer, then you should be suspecting ulcerative colitis in those patients. So yeah, that's just one thing to bear in mind. Okay, some images for everybody. Let's take a look. Anyone know what this is? Where's the chat gone? Good. Nihit Soni smashed it. Pyoderma gangrenosum. So this is pyoderma gangrenosum on a patient's back. Pretty nasty, as you can tell. So it's this rare inflammatory skin condition. You get painful pustules, nodules. They can become ulcers as well, and they grow progressively. So it's not infectious, it's inflammatory, and it is an extra-intestinal manifestation of ulcerative colitis. So that's what it looks like. It can look different on different parts of the body, of course, but yeah, that's just so you guys can visualize that. Okay, I have lots more images as well coming up. So next question: which of the following features is more frequently seen in ulcerative colitis than in Crohn's disease? Let's get this one up. There we go. Okay. Chat, Q&A. Would you tell a UC smoker that smoking is known to reduce the severity? Yeah, I mean, I think often what's going to happen is that patients with UC say, oh, I find that when I smoke, my symptoms aren't as severe. And I think, it's really important to be honest with them and say, actually, yes, we know that, there's evidence for that, but you also need to be aware of the risks of smoking as well. So, offer smoking cessation, but also be very, very careful and be very, very honest with patients that their symptoms may become more severe, and therefore you may need to optimize their medical therapy as well. Okay, where's that question gone? I think I've answered that. Why is the question about UC smoker inappropriate? I'm not sure what that's referring to. Sorry. Nice, good, absolutely right. Colorectal cancer, lovely. Well, not lovely, it's very sad, but yes, ulcerative colitis is a very, very important risk factor for colorectal cancer, more so than Crohn's disease. Crohn's disease, there is a modest risk, increased risk of colorectal cancer, but it's much more significant in ulcerative colitis. And the other ones are incorrect for the reasons given here. Okay, great. So moving on to some extra-intestinal manifestations. So these are shared manifestations between ulcerative colitis and Crohn's disease, in that hypothetically and theoretically, both conditions can cause these extra-intestinal manifestations, but some of them are going to be more common in UC and some of them are going to be more common in Crohn's. So let me move the Q&A out the way. So a few points, and as I said, I've got some images as well. A few points that I wanted to highlight. So I highlighted this in the Crohn's webinar as well. Arthritis is the most common extra-intestinal manifestation in both Crohn's disease and ulcerative colitis. But that's just something to be aware of. Next thing I wanted to highlight, so this PSC stands for primary sclerosing cholangitis. It can occur in Crohn's disease, but it is far, far more common in patients with ulcerative colitis. And for those of you who don't know what primary sclerosing cholangitis is, it's essentially just this long-term progressive disease of the liver and the gallbladder, the bile ducts really, and it's characterized by inflammation and scarring of those bile ducts. It's thought to be an autoimmune condition, and it's far more common in patients with ulcerative colitis. And similarly, uveitis is more common in patients with ulcerative colitis as well, as is autoimmune hepatitis. So just a few specific extra-intestinal manifestations which are more common in UC than in Crohn's. So nice and easy. What's this, friends? What do we think this is? Oops. Nodosum, good. Erythema nodosum. Lots of people messaging things. Good. Yeah, erythema nodosum, good. So these painful nodules, usually on the shins, an extra-intestinal manifestation. So keep an eye out for that. What's this? Any thoughts? Good. Pyoderma again. So this is pyoderma gangrenosum, like we mentioned before. I said it can look slightly different on different parts of the body. This is what it looks like here. So just compare that to the image on the back as well. So that's just something to be aware of. Cool. Anyone know what this is? Anyone? Good. This is episcleritis. This is episcleritis, more common in Crohn's disease than in ulcerative colitis. Whereas a lot of people are saying the other ophthalmological condition, which is this. Well, this is a really, really nasty version of it, but what's this one? Good, uveitis. So this is a really, really nasty uveitis. So this is the anterior uveitis, inflammation of your anterior chamber of your eye. You have hyperpynon here actually. So right, you see this like meniscus-y type line, this yellowish exudate. This is hypopynon. It's not particularly pleasant. So this is really bad uveitis essentially, which is more common in ulcerative colitis, as we said. Lovely. Okay, moving on to some investigations. This is essentially the same as what you would do in Crohn's disease, with a few little differences as well. So all of these are as per NICE CKS 2020 guidelines. So bedside, blood, imaging, that's how we like to do things around here. So fecal calprotectin, as I mentioned in the previous webinar, this is a useful stool-based investigation to help differentiate between irritable bowel syndrome and inflammatory bowel disease. So you'd expect a patient with ulcerative colitis to have an elevated fecal calprotectin, because this this indicates the migration of neutrophils to the intestinal mucosa. So any patient with inflammatory bowel disease, you would expect the fecal calprotectin to be raised, whereas if you had irritable bowel syndrome, where there is no structural problem, there is no inflammation as such, fecal calprotectin will be normal. Next bedside investigation, as per NICE, that you should do stool microscopy and culture. This is really to exclude other causes of the patient's symptoms rather than to diagnose ulcerative colitis. Moving on to blood. So these are a few specific bloods that you're advised to do. So full blood count, you could have anemia due to various different things. As we said, malabsorption, malnutrition is more common in Crohn's, but is possible in ulcerative colitis as well. And if you're having a flare of your disease, then you could expect your white cell count to be significantly elevated as well. Similarly, if you're having a flare, CRP correlates with your disease activity. ESR is really important when you are calculating the disease severity or the severity of a flare in ulcerative colitis as well. So make sure you measure that as well. Renal function and electrolytes, these patients can become very dehydrated. They lose a lot of fluid via the rectum because they've got so much diarrhea, and they can get quite a profound pre-renal acute kidney injury as well. So make sure you check the renal function. And similarly, they can lose a lot of electrolytes, and you can get a lot of electrolyte imbalances as well. So yes, that's why we're doing U's and E's. Nutritional status, as we said, really important to assess, as are the liver function, patient's liver function tests as well. You can lose a lot of protein, and a low serum albumin could suggest a protein losing enteropathy. And then finally, celiac disease in terms of blood. So this is, once again, it's not to diagnose ulcerative colitis, it's to exclude alternative pathology such as celiac disease. So you could measure the patient's anti-TTG, for example. So yeah, those are the bloods that you would request in a patient with suspected ulcerative colitis, as per NICE. Fine. So before we move on to further investigations, which of the following would not be expected? So it's a negative question. Which of the following would not be expected on colonoscopy and biopsy in this patient with suspected ulcerative colitis? So he's been referred for further investigations. Which of the following would not be expected on colonoscopy and biopsy? Lots of questions. Will the SJT teaching be free? Yes, it will be free, indeed. I believe so. When will you guys do Menti Q&As again? Like actual Q&As. I mean, we do Q&As at the end of every webinar, I guess. But if you mean like an actual long Q&A with Schwabe and I, we kind of stopped those for various reasons. NICE CKS is NICE clinical knowledge summaries. Is there any difference between CKS and regular NICE guidelines? CKS is generally more summarized, but there are often slight discrepancies, and one is often updated before the other one. They vary a little bit, so I normally check them both before I write them anywhere, because often one is more up to date, but they usually don't differ massively. Okay. See, good. Guys are doing good. Smashed it. Well done. Absolutely right. So there you go. That is the main thing that you would not expect on colonoscopy and biopsy in a patient with ulcerative colitis. So granulomas, which they're these essentially these focal aggregates of immune cells that form in response to persistent inflammation. If you look at the Crohn's webinar, you'll see some nice images of granulomas. These are much more commonly seen in Crohn's disease and infrequently seen in ulcerative colitis, whereas all of these other findings can be seen on ulcerative colitis and often are seen in ulcerative colitis. Okie dokie. So moving on to some more imaging / invasive investigations. So there's often some discrepancy or like controversy as to, you know, how are we going to diagnose UC? Like, can you just do a flexible sigmoidoscopy? Can you do a rigid sigmoidoscopy? Do you need to do a colonoscopy? Well, looking at the literature, you know, still a colonoscopy for any patient with suspected inflammatory bowel disease, you need to do a colonoscopy, i.e. an assessment of the entire large bowel, not just up to the sigmoid. So if you look at the guidelines by the European Crohn's and Colitis Organization, they say that for suspected inflammatory bowel disease, an ileocolonoscopy with biopsies from your inflamed and uninflamed segments are required to establish a diagnosis. There will be times where sigmoidoscopies will suffice, but in stable patients, to establish the diagnosis, you're going to want to do a colonoscopy with biopsies. What are we looking for? Well, red and raw mucosa with widespread shallow ulceration because it's affecting the mucosa and submucosa. That's why it's shallow. On histology, no inflammation beyond the submucosa. On the whole, there are some cases like fulminant disease where you may get some further inflammation, but I wouldn't worry about that. On the whole, no inflammation beyond the submucosa because you would expect that in Crohn's disease. Pseudopolyps, crypt abscesses, goblet cell depletion, and then infrequent granulomas. So most of these we have touched on already. So as per the European Crohn's and Colitis Organization, they state that the most useful endoscopic features of UC are considered to be the continuous and confluent colonic involvement with clear demarcation of inflammation and rectal involvement. So continuous, confluent colonic involvement with clear demarcation of inflammation and rectal involvement. If you have that, you can be quite confident that you've got ulcerative colitis. Okay, so some investigations to consider. I wouldn't get too bogged down in these. When are you going to do sigmoidoscopy? Well, as we said before, ideally in stable patients to diagnose inflammatory bowel disease, you're going to want to image and directly visualize and biopsy the entire large bowel. If a patient is having an acute flare, sigmoidoscopy is preferred to avoid perforation. And that's per those guidelines as well. A few other investigations you can consider: CT abdomen pelvis, you can see inflammation, you can see any complications such as strictures as well. An abdominal X-ray, classically at med school it's described as this lead pipe appearance. I'll show you what that looks like later on. But essentially it's this featureless, smooth appearance of the diseased segment of large bowel. So that lead pipe appearance would suggest chronic ulcerative colitis. But similarly, an abdofilm is relatively good at picking up any big complications like toxic megacolon, which we'll talk about later as well. If you did a barium enema, similarly, you can get this lead pipe appearance as well due to the loss of haustration and pseudopolyps. And then finally, serum antibody markers. These are not routinely done in the assessment of inflammatory bowel disease, but if it ever does come up in your exams, then P-anchor is what you would expect in UC, whereas ASCA is what you would expect in Crohn's disease. But as I said, not routinely done in clinical practice. Cool. Got some images. These are the ones we essentially looked at before, but to put it in the context of colonoscopy and biopsy, you put the bits under the slide, and this is the kind of stuff you would expect to see. So lymphocytic infiltration of the intestinal mucosa, disruption of your crypts, and crypt abscesses as well. You know, these are the types of things you would expect on biopsy. Anyone knows what these are? Like cauliflower-ish looking things. I wouldn't really expect anyone to know what these are, but I'll tell you. These are, so this is a photo from a patient with ulcerative colitis. So they had clinically incredibly severe, intractable, chronic ulcerative colitis. They did a total colectomy. And this photo basically just shows this shaggy carpet of inflammatory pseudopolyps. So these are pseudopolyps. So essentially, they're these projecting masses of scar tissue which look very much like polyps but are not polyps. They develop from granulation tissue during the healing process when you get repeated cycles of ulceration. So these are what pseudopolyps look like if you ever wanted to visualize it. So essentially, all pseudopolyps represent are repeated previous episodes of severe inflammation and ulceration of the mucosa. So some people are saying they look like noodles, some people saying they look like baked beans. Whatever you think they look like, you know, whatever helps you memorize it, I'm happy with. Good. So this is an endoscopic image of a patient with ulcerative colitis affecting the left side of their colon. It shows confluent superficial ulceration and loss of your mucosal architecture. Now, on first appearance, Crohn's disease may have a similar appearance. So just by visualizing it can make it difficult to differentiate between the two. But this is what this is showing here, left-sided confluent ulceration, which suggests ulcerative colitis. This over here, this is just a loss of the vascular pattern of the sigmoid colon with granularity as well. So obviously you're not going to be expected to, you know, interpret these images in your exams. It's more just for visual learners who like to see things like myself. This can help to put things into context for you. Okay, so moving back onto our chap, 25-year-old guy. I want you to really take in everything that's on the screen now. So take in his history, his observations, and the basic preliminary bloods that have been done. And I want you to think, you know, what is the patient's severity or disease severity as per the True Love and Wits severity criteria? But you have to really, I'm not going to change slides yet because you have to take in absolutely every bit of information really. And make sure to answer on Menti. I'll give you guys 20 seconds to read that to determine what you guys think the severity is. Let's see the chat. Best resources to read histology and how extensively should med students know about histology? I think beyond preclinical years, histology in terms of actually interpreting histopathological slides is very, very minimal in terms of exams and how much you need to know. For clinical exams, you really need to know those descriptions that we have covered already today. In terms of best resources, I think Schwabe talks about pathoma a lot. I actually don't know what's in pathoma, but it sounds like it's a good resource for pathology. I can't actually remember what I use for my pathology stuff. So yeah, hopefully you guys have taken that history and, oh dear, what's happened here? Why did that happen? One sec. Let's make sure this works. Okay. So I've paused the share just because I don't want everyone to see the answer, but 75% of you have said mild, and mild is absolutely correct. Mild is absolutely correct. Let me bring my screen back. Can you guys see that now? Yeah. Good. So yeah, 3/4 of you, 75% of you said mild. The rest of you really said moderate. So you guys probably just from the history alone can tell that this isn't a particularly severe case of ulcerative colitis, but it's also important to know which criteria you need to take into account when assessing severity, because this is exactly what NICE say, that all patients with a flare-up of their ulcerative colitis or a first presentation of symptomatic ulcerative colitis, you need to assess their severity as per True Love and Wits. So this is taken and adapted from NICE. I mean, it's not particularly difficult to learn, to be honest. It's nice and straightforward. So you can learn it if you'd like, but certainly learn which factors are taken into account. So the number of bowel movements per day, the presence of blood in the stools, whether the patient is tachycardic, whether the patient has a temperature, whether the patient is anemic, and what their ESR is. As I said, it's not hard to learn those cutoffs, so please do if you can. If not, learn the bare minimum. And this is really, really important because this is what's going to affect your management as well. So the one to really be aware of here is going to be severe. So if you have 6 bowel movements a day, for example, and no features of systemic upset, so which are marked with these asterisks over here, then actually you would fall in the moderate category because it's 6 bowel movements with no features of systemic upset. If you have 6 or more bowel movements per day with any one of these features of systemic upset, you're classified as having severe ulcerative colitis. So that's really the only slightly tricky thing on here. But once you've got your head around that, the rest is really, really straightforward. The cutoffs are easy, and make sure you check the patient's ESR, make sure you check their HB as well. So yeah, absolutely right. This patient has a mild flare of their ulcerative colitis. So moving on to management, hopefully you've learnt that table or have it in front of you somewhere, because that's what's going to affect our management now. 2 general points regarding the management of ulcerative colitis. In Crohn's, methotrexate is often used. In ulcerative colitis, it's not advocated, mainly because it's probably not particularly effective and it's associated with side effects. So when you balance out the risk benefit, that's probably why it's not used in UC. And also, as per NICE, there may be some role for probiotics in preventing relapse, but only in the most mildish forms of the disease. On the whole, pharmacological management is going to be used. Okay, so we have this chap here. He's referred for further investigations and he's diagnosed with mild proctitis secondary to ulcerative colitis. How are you going to manage this chap? Hopefully you have the question on your screen. I just want to pause the share because I just want to make sure that this isn't giving away the answer. Good, okay, let's bring it back. Okay, so I'll let a few more of you answer that. So we think, well, he's been diagnosed with mild proctitis secondary to ulcerative colitis. How are we going to manage this guy? Let's have a look at the questions. Were you guys good at histology? I really was not particularly good at histology, to be honest. How do you differentiate polyps and pseudopolyps? Yes, histologically correct. Okay, I'll come back to the Q&A later. Okay, a little bit of a split there. Okay, let's see. Oh, let's not do that. Let's do this. So 1/3 of you said topical mesalazine, and you guys are correct. So as I said before, the management of UC is not massively exhilarating. There's quite a bit to learn, but it's just a question of sitting down and learning it. So this patient who has, sorry, that should say mild, not mid to moderate. So patients with mild to moderate disease, topical mesalazine is going to be first line. That's just a rule that you need to learn. And essentially what you need to learn is just the tables that are on the next few slides. I'm not going to get massively bogged down in it because, as I said, it's not massively exciting. But essentially how you're going to determine the management is going to be the severity as per true love and width. Remember that table? So has the patient got mild, moderate, or severe disease? So this is initially all about inducing remission. The patient has a flare, they've got a mild flare, a moderate flare, or a severe flare. And you literally just plug it into the true love and width table, and that can help you answer that question. You then need to investigate and determine, has this patient, to what extent has this patient got diseased colon? Have they got proctitis? Remember that initial diagram I showed you right at the start and told you to remember? That one. So has the patient got proctitis, sigmoiditis, left-sided colitis, or more extensive disease? Once you've answered those 2 questions, you can then determine how you're going to induce remission in these patients with a flare. As I said before, mild to moderate UC, first line is going to be a topical ASA, so topical aminosalicylate. So something like, and when I say topical, I mean suppository or enema. So for example, a mesalazine suppository would be an example of a topical ASA. So that's first line in mild to moderate proctitis, first line mild to moderate proctosigmoiditis, and left-sided colitis limited to the splenic flexure. We're going to give these patients topical therapy. If remission isn't achieved within 4 weeks, we can then add on some other medication depending on the extent of the diseased part of the bowel. As it says here, either an oral amino salicylate or increasing the dose of or a high dose oral mesalazine, for example, or a high dose oral mesalazine and a topical corticosteroid. Essentially, learn this table. It's actually relatively straightforward when you think about it. And then obviously third line in slightly more significant disease, so up to the splenic flexure where this black line is, you're going to stop topical therapy because this patient needs something stronger, and you're going to commence high dose oral ASA and an oral corticosteroid as well. So that's how you're going to induce remission in mild to moderate UC. When you have mild to moderate UC that is more extensive, you're still going to use a topical ASA like mesalazine, but once it's extending, beyond the splenic flexure, you're also going to use a high dose oral ASA in addition to that. So actually, it's quite a straightforward rule. Once it's extended proximal to the splenic flexure, in mild to moderate disease, you add a high dose oral ASA like mesalazine. Then, if you've done that and remission still isn't achieved within 4 weeks, as before, stop topical therapy, and then you're going to commence high dose oral ASA and an oral corticosteroid. So actually, quite similar and relatively straightforward, I think. Now, a really important differentiating feature in acute severe colitis is that regardless of the extent of the disease, how far that inflammation extends, if you have acute severe colitis, this is what you're going to need to do. And obviously all of this is as per NICE guidelines. So the first thing you're going to do is admit the patient. You're going to give them an IV corticosteroid. There are alternatives, for example, cyclosporin. If IV corticosteroid is not appropriate, then let's say you give a corticosteroid, IV corticosteroid, and things still haven't improved, then you need to think, can I add on IV cyclosporin to that corticosteroid? And the answer is yes, you can. And then you need to think, which patients are going to benefit from adding cyclosporin, which is obviously a strong immunosuppressant. What's the benefit of adding that to corticosteroids? So there are a couple of circumstances when you're then going to add cyclosporin to a corticosteroid. So if you have a patient who has little or no improvement in their symptoms within 72 hours of starting IV corticosteroids, so 72 hours, you're going to add IV cyclosporin, or in a patient whose symptoms worsen at any time despite corticosteroids, you're going to add IV cyclosporin. So if symptoms don't improve within 72 hours on IV corticosteroids, or if symptoms worsen at any point despite IV corticosteroids, you're going to add IV cyclosporin, or IV infliximab if cyclosporin is contraindicated. So that's just one caveat to that rule. And then finally, just a key point here is that there is no third line medical management for severe colitis. As per NICE and also the Crohn's and colitis guidelines, once you have a patient with severe colitis who has failed their second line management, you need to be thinking about surgery, not adding more drugs. So that's just another rule to remember as well. So that's how you're going to induce remission. That's really a summary of a lot of pages of guidelines. So it's relatively simplified, but more than what you need to know for examination purposes. So let's imagine you then have a chap let's even talk about this patient in the first case. You've induced remission, patient is stabilized. You then need to think, how are we going to maintain remission in these patients? So once again, think about the severity of their their UC, think about the extent of their UC, and essentially it's just going to be this: proctitis, which is mild to moderate, topical ASA, or oral ASA with topical ASA, or an oral ASA alone. There you go. And then proctosigmoiditis and left-sided colitis. If it's proctosigmoiditis, you're going to treat as per the first row here. And if it's left-sided colitis, it's going to be a low maintenance dose of an oral ASA. I told you guys before, this is not very sexy, and I'm sorry about that, but just learn these few tables. So that's that. And then we have to think about how we're going to maintain remission in more extensive disease and more severe disease. Well, if you have extensive disease proximal to the splenic flexure, you have to maintain remission with a low maintenance dose of an oral ASA. And then finally, acute severe colitis, that's when we need to start considering things like oral azathioprine or mercaptopurine, particularly, to maintain remission in these patients. Because obviously these are strong immunosuppressants, and you don't want a patient who's just had acute severe colitis to suddenly have a relapse of a similar severity flare again. And that's why you want to put them on a more stronger immunosuppressant like azathioprine. There's finally, this rule here, which is very specifically stated by NICE, in that in a patient who has had 2 or more exacerbations in the past year, really regardless of the severity, but if they've needed systemic corticosteroids, or their remission isn't maintained by ASAs, then we also need to consider stronger immunosuppressants as well. That's just an additional rule. So it's not just going to be acute severe colitis patients that need azathioprine to maintain their remission. It's also this other subgroup of patients that may require oral azathioprine or mercaptopurine to maintain remission as well. So yeah, just remember that. And to be honest, that's all. I say that's all you need to know about management. That is quite a bit. But as I said, learn those tables, and that's more than what you need to know for your exams. And you should be very confident if you can learn those tables. So yeah, good. How am I doing for time? Oh, not great. So yeah, might be, yeah, probably another 10 minutes or so, I reckon. So moving on to surgical options. So surgical options in UC are potentially curative because obviously there are continuous lesions, so you can cut out the affected portion of bowel. Whereas in Crohn's disease, where you have skip lesions, surgery is not curative. So what are the surgical options for these patients? So if you have a severe flare or fulminant disease, which essentially just means abrupt, severe onset of UC, which has separate criteria you don't need to worry about, but just know it's really acutely severe UC, then we need to consider surgery. If there's no improvement of symptoms despite treatment escalation, or patients are super, super sick, then there are numerous colectomy options. So you essentially chop out portions of bowel. So for example, you could do a Hartmann's in an emergency setting. So which is, and for those of you who don't know what Hartmann's is, it's resection of your rectosigmoid colon and then closure of your anorectal stump, and you form an end colostomy. So that's going to be emergency surgery for a patient with really, really severe ulcerative colitis. So that's acute management. Whereas in patients with ongoing symptoms, who essentially, they've tried lots of medical therapy, they have intractable symptoms despite that, or ongoing adverse medication side effects, which are intolerable, then we can also offer curative surgery as well. So most commonly, what's going to be done is a proctocolectomy and formation of what's called an ilioanal pouch, which is what's shown here. You don't need to know much more in terms of surgery other than what I've described here, to be honest. But essentially what this surgery is describing, and it is a curative surgery for UC, is that it's the removal of your colon and rectum, and then you use the end of your small intestine, so your ileum, to form an internal pouch, which is shaped like a J, and that's why it's called a J pouch or an ilioanal pouch. So it's essentially this pouch or reservoir, which is made from loops of your ileum and joined back to the anus, which is what you can see here, which is essentially a new rectum that you're formed from your small bowel. So that's the most commonly performed curative procedure for ongoing intractable symptoms of ulcerative colitis. Okay, moving on. Now these slides I'm not going to dwell on massively. This is really just so you guys can take home and read about this in your own time, in terms of how you differentiate between Crohn's and UC in terms of various different factors. So you can differentiate in terms of symptoms, the risk of smoking or the risks associated with smoking and what happens when you smoke with these two conditions. You can differentiate in terms of pathology, the location of the diseased portion of bowel, and histology as well, as we've talked about quite a bit previously. So have a read of that in your own time as well. This is a diagram that simply just shows like visual representation of how you can differentiate between the two conditions. So Crohn's have these skip lesions like we talked about in the previous webinar, and ulcerative colitis has these continuous lesions here, and that's why surgery is curative in ulcerative colitis. And just a few other ways in which you can differentiate between UC and Crohn's disease. Now, one thing I did want to touch on here is going to be toxic megacolon. This is mainly because a lot of people have questions about toxic megacolon all the time. So let's touch a little bit and briefly on toxic megacolon as well. So for those of you who haven't heard of toxic megacolon, it's essentially an acute form of colonic distension which can occur in patients with ulcerative colitis. So, severe colitis or fulminant disease is seen in around 15% of patients with UC. 20% of those patients can then progress to toxic megacolon, which is what's shown in the abdominal X-ray on the right over there. So essentially, it's the acute distension and dilatation of your large bowel, and this can then perforate. Patients can become septic and they can die. So it's an emergency that needs to be managed expediently. So you need supportive care, pop an NG tube in, decompress, and you need to give IV antibiotics and monitor really, really closely. So, and obviously if things don't improve, then these patients are going to need emergency surgery. There are numerous precipitating factors for toxic megacolon as per NICE, things like infection, hypokalemia, hypomagnesemia. You don't need to get into massive amount of details regarding that, but just know how you would notice this. So you can see this lead pipe bowel here. It's acutely dilated bowel. Yeah, so this you need to manage ASAP to avoid these complications and avoid surgery as much as possible. Good. So some complications. We've touched on toxic megacolon. Most of these we have mentioned already. There are some treatment-related ones. This is exactly the same as the treatment-related side effects mentioned in the Crohn's disease webinar, mainly associated with immunosuppression and the risks associated with that. So those are a few complications just to be aware of. Interestingly, despite all those complications, despite everything we've said, overall, there doesn't actually appear to be an increased rate of mortality in patients with UC, which is reassuring. And the evidence actually suggests that the most common cause of death is toxic megacolon. And that's why it's so important to be aware of how to diagnose it and what you will do if the patient has this complication. And in terms of colon cancer, which we touched on previously, this occurs in around 3 to 5% of patients with ulcerative colitis. And that leads us on really nicely to our top decile question, which is actually kind of on the topic of colon cancer in inflammatory bowel disease. So let's see if this works. Top decile question, and then we're finishing off a few minutes behind schedule. Sorry about that. Everyone join. I think it's the same code. Question 1 of 1. the faster you answer, the more points you get. Sorry, we have no prizes for you, but we'll see what we can do. We'll hold another competition, basically, so you guys can get some more prizes. Now, this is a really tough question. Knowing you guys, you'll probably get it, which is super annoying, but, oh gosh, that fell down. But yeah, I definitely wouldn't have got this at med school, so let's see. I'll let you crack on. Okay, 30 seconds left. Fifteen seconds. All right, let's see. Whoa. Okay. Not bad. This is a hard question. So you've got a male, he's had ulcerative colitis for 20 years, which is extensive but quiescent. His mum had colorectal cancer at the age of 52 years old. We know that patients with ulcerative colitis are at increased risk of colorectal cancer. And in this patient, you're going to offer colonoscopy at 3 years. This would be a really unfair question for you to get asked in your exams, just because it's relatively niche and there's lots of criteria that you would need to learn for you to get this question correct. So yeah, that's absolutely right. So offer colonoscopy at 3 years. And the logic behind this is that as per NICE, the 2011 guidelines, so all patients with inflammatory bowel disease whose symptoms started more than 10 years ago, who have ulcerative colitis or Crohn's colitis affecting more than one segment, need some kind of colonoscopic surveillance to detect some of those dysplastic changes associated with colorectal cancer. You do not need to learn all these bullet points. That's why it's a top decile question. But if you ever did want to know or learn this, then that's essentially what it is. Low risk are these 3 bullet points. That's 5-year surveillance. Intermediate risk, which this patient was because she had his mum, who's a first-degree relative at 52 years old, had colorectal cancer. That's why he's having 3-year surveillance. And then finally, 1-year surveillance if you're high risk, which is any of these. As I said, please don't get bogged down in this. Don't think that you're going to fail because you don't know this. This is very, very, very top decile. So let's see who came first. And then we're all done for the day. Bell. Ooh, that was very close. Bell, take a bow. You have absolutely smashed it. Well done to everyone else on that leaderboard. You are all fantastic and you are all brilliant. Well done. Now, let me... Oh. Okay, we're done. We are done. I'm sorry, 4 minutes behind schedule, but fantastic work, everyone. Please do leave feedback. I'll give you the feedback link in a second. You are on our platform, so please do check out our question bank, which has all these multi-step SBAs, our textbook based on the most recent guidelines. If you supplement the webinars with the textbook and the questions, you'll smash it. So we'd really recommend that. And please leave feedback because that's the only way we can improve. So please do leave feedback. I'll stick around for a few questions, but I may need to rush off. So sorry about that. But let me pop the feedback link here. Thank you so much to everyone for joining, of course. You guys are great. Schwabe, I think, will be here on Friday to talk about platelet and clotting disorders, I believe. So be sure to check that out. Please tell your friends about us, because that's the only way we survive. And please leave your feedback. Thank you so very much. Thanks for joining us. I only have time for a couple of questions just because I need to rush off, so sorry about that. So I'll take lots of questions. Okay. So what is the secret behind how you all can so amazingly summarize nice guidelines? Any tips so I can read it more efficiently? I think it just comes with practice, I guess. Like I learned by nice guidelines weren't really very easy to digest at med school at all when I was at med school. Things are a lot more simple now. But only the last few years when we've started having to summarize them for work and for biomedicine, it just becomes simpler the more you do it. It's just take the main subheadings and categorize it into the areas that you need to learn, and then try and make tables. That's what we like to do. Tables and flowcharts is what I like personally. Can you repeat again what will be seen in colonoscopy? So, I mean, just take a look back at those slides. If you're talking about what would be strongly suggestive on colonoscopy, so as per the Crohn's and Colitis Association, you would expect, continuous, contiguous inflammation of a portion of bowel with rectal involvement would be strongly suggestive of ulcerative colitis. Okay, I don't know. None of these are really specific questions. When is adalimumab given in UC? I'm not entirely sure. I mentioned one other biologic. I think it was infliximab I mentioned before. I'm not sure specifically about adalimumab, unfortunately. But yeah, check out the NICE guidelines. It may be different to infliximab. I'm not entirely sure. Yeah, I'm sorry I don't have time to take more of those questions. Thank you so much to Shweb for answering, almost 50 questions. So thank you so much for that, mate. And we'll see you all on Friday. Thank you for sticking around. As I said, sorry I couldn't take more questions. I just have a meeting to get to right now. But I wish you all the best, and take care of yourselves. Have a wonderful Wednesday evening. Goodbye.